talking really about neuro rehabilitation, but from a top-down perspective. So when we're talking about a bottom-up, we might be working with taping, we might be working with tool-assisted soft tissue work, we might be working with proprioception, all the inputs coming from the bottom up. But when we want to think about rehabilitation from a top-down, we have to think about what are those sensory systems that might be influencing the motor system, the muscular system. So we're thinking about the visual system, but for here today we want to look at how does the vestibular system influence the muscular system in a rehab perspective. So what we're going to do with Jessica here is we're going to have her stand on a perturbed surface, a foam pad. So when we look at the different types of perturbed surfaces or pads, when we stand on these, we actually upweight the vestibular system. What that means is that when we're standing on a firm surface, our primary input is proprioceptive. So we got muscles, mechanoreceptors, muscle spindles, giving information into the central axis, if you will, or the neuraxis. And this is going to, that information is going to help us move smoothly through the environment, whether it's athletics or whether it's just day-to-day movement. But when we stand on this, all of a sudden the vestibular system says, hey, I'm the predominant one, like if you were in a boat. So you may not have a good firm surface, and the vestibular system is now what we're really looking at in a general way. So let's say we have about 60 to 70% proprioceptive input here, and about 10 to 20% is the vestibular input, and then 10% vision. So that flips around, and now we're going to look at more vestibular inputs. So what you would do in an office, or with an athlete, or with any of your patients, you'd have them stand on a foam or perturbed surface. And you'd want to see what their general stability levels are. So we would just look at this here, and we always, one more time, always want to maintain a safe position for a patient. So whether we stand them on here before they close their eyes, then we'd want to make sure we'd have additional staff around them so that if there's any imbalance, they would not have any fall risk. So what we would do, we'll have you close your eyes, and we just want to assess what's the stability, and they'll have sway. Open your eyes. So sway is normal. Everyone has sway, but how much sway you have is what's important to assess. So you can assess it subjectively by looking at how much sway they have, and we can do different tests to evaluate the right or the left vestibular system. So what we can do to do that, so now again, we have proprioceptive input that we're considering here. Turn your head to the right. As we turn the head to the right, we're activating more the right vestibular system, and we'd have her close her eyes, and we would watch, is there sway here compared to when she was in the middle? Is it greater? And we would do this for 20 to 30 seconds. Open your eyes, bring your head back to middle. So if she had a lot of sway there compared to the center or the left, we might now start to assume the right vestibular system is not functioning at a level that the other side is. So there's not a symmetry. And then I'll tie this into the musculoskeletal. So we would go left also. Close your eyes. Again, observing for sway. Which direction is the sway? How much is the sway? And it looks as if, open your eyes, that she has a bit more sway when she turns her head to the left. Just in this. Now we would do this on the foam platform or on a foam surface. The other foam surface we would use, or air-related surface, has a greater degree of sway. So depending on the age of the patient, depending on their stability, we might use something like this for her to really open up how much imbalance there is. But we're going to say that it looks like right now, when she turns her head left, there's greater sway. Did you feel that way? Okay. So if you have less vestibular input from one side, even in the absence of dizziness, and this is important, people will say, well, I don't have vertigo, I'm not dizzy, but you can actually bring out, like a stress test, an imbalance that is coming from a vestibular input, and this relationship to the muscular system is this. So we have just a little background, the vestibulospinal pathways that control extensor muscles. So it's the fastest firing system in our nervous, it's the fastest, so it's going to protect us so we don't fall if we're starting to go off of our center axis, when you go beyond your limit of stability. Okay, there's the background. So when she turns her head this way, and if she starts to have a lot of sway, and we think there's a left vestibular problem, bring her back here. Now we're going to get into this a little more carefully. We have an anterior canal posterior canal, and a horizontal canal. So for what we might do is bring her head into the anterior position, have her, don't do it right now, close her eyes and assess, is this the greater pattern? Or is the posterior the greater pattern of sway, or the horizontal? So now we can get down not only to the side, but the potential canal. You say, well, why? One thing is documenting that. Now you're also finding in the history, have they had any head impacts? Did they play any sports where they've had any issues with that? But if she has a right anterior canal imbalance, so let's just see how she does. Head here, close your eyes. Looks pretty good there. Come back, head back this way, this side, close your eyes. Back to the center, we see that there's more there. Now there will be more sway in a posterior position. And of course, you would say there could be cervical contributions. I agree. So we need to assess those things. But I'm assuming you've already done that because you already are looking at bottom-up mechanisms, cervical proprioception. Is there range of motion? Good. You would have already assessed that. This is an additional piece that you would consider in the overall rehab picture. So if we would assume she has a posterior canal imbalance, let's just say it that way, in the absence of any complaint of dizziness, we might talk to her about right extensor muscles that might be a problem. She might have something in her right IT band. Why would she have some chronic potential tightness, tension, or pain in any of the extensors on the front right? Because when you have a left posterior canal imbalance, whenever that canal is fired, the left posterior, you're firing your right extensors on the front to bring you back. So they may have a chronic imbalance going on that we might be working with taping, tool, foam roller, everything. But we may actually need to treat the canal and the soft tissue to meet in the middle and have a better long-term result. So when we analyze vestibular mechanisms in relation to a muscular complaint or a presenting condition, we may find an additional piece that gives them the long-term outcome that many times they haven't been able to find in other places, or that we keep treating with some degree of success, but we want to get to another level. So chronic muscular injuries, vestibular system, there's a relationship. This is the way to assess that.